Health inequities are not new. And if we're honest about it, as a nation and as a world, we haven't done that good a job of it, really. Europe has had similar experiences, so this is not just a problem in the United States. And at least from my perspective, progress will require serious, thoughtful, honest, and respectful open dialogue and collaboration. That's exactly what we want to bring to you today. We hope to talk amongst ourselves and then open it up to you to engage. Some of the topics may be a little bit tough, but certainly we'll be respectful and open and hopefully leave with new insights. And with that, why don't I turn it to the panel, and why don't I have each one of you introduce yourselves and your organization and start by telling us what health equity means to you in the context of your role.
Thank you. Good afternoon, everyone. My name is Sharon Deans. As I was introduced, I'm Regional Vice President for Clinical Services, Strategy and Operations for Elevance Health, formerly Anthem, in the Medicaid book of business, which is my passion. Health equity. First of all, healthcare is not a zero-sum game. There's enough to go around for everyone. We have to acknowledge the work that we need to do around health equity. But health equity itself is the total person. A few weeks ago in Charlotte, where I live, I got lost going to my friend's house. I missed a turn. And I see everybody jogging very safely in their neighborhood, people out strolling with the baby. And I'm thinking, this is a microcosm, and I can drive 5 miles from here, and people are not outside their homes because their communities are not safe. So it's not just delivery of health care, it's the person, where they live, the opportunities they have, how they're perceived as they travel and work on a daily basis. If you think about it, when you are out every day, you're categorizing everything. That's what we do in the United States. I have some biracial grandchildren, and I'm concerned on what's going to happen to them when they can't check a box on exactly who they are, and we want everybody to check a box. And so that conscious effort to manage our unconscious biases is really, really important. And to have the difficult conversations is also a commitment. It's painful, but it's necessary.
Good afternoon. Oh, never like to hear your own voice. How are you? I'm Tara Hayden. I'm the Vice President of Community Health Equity for Jefferson Health, which is the second largest health system in the southeastern Pennsylvania region. We also have an entity for which I have responsibility, which is known as the Jefferson Collaborative for Health Equity. So the collaborative is a unique opportunity, which is what brought me to Jefferson, where we address the complex issues related to health inequities facing our communities by aligning resources, building partnerships, forging trust, and relationships that create sustainable changes. We build on the community's strengths to improve the health and well-being, fostering local ecosystems necessary to promote health equity and help everyone in our communities reach their full potential. So then what is health equity to me? It means that where you live, where you're born, and who you are does not determine your access and the treatment you receive when you interface with the healthcare system. When you show up, your humanity is seen, your voice is heard, and your care is based on best practices, not perceptions of who you are and who you are not. This allows for the attainment of the highest level of health for all persons. So we were having some conversations as we sat here, and it's difficult not to, and our colleague here said we're going to have some difficult conversations. So I'll start some of those difficult conversations. It's hard not to do this work without thinking about those individuals who don't have advocates for themselves when they enter the healthcare system. In a city like Philadelphia, where Jefferson is, we are one of the largest, poorest cities in America. If you're born in a zip code of 19132, you live 20 years less than if you live in Center City in Rittenhouse. And as I tell my team, We're in this beautiful building on 1101 Market Street, looking out the window, and it's pretty opulent, depending on which side of the building you're on. My husband is a native Philadelphian. He grew up in the poorest zip code in Philadelphia. So when I do this work, it's very personal. And when I've been very frustrated by the things that I'm having to navigate and the way the systems don't respond to our community, he says to me when I get out of the car in the morning, "You're doing it for a little boy like me. I needed advocates, and I didn't often have them. You're in a place to advocate for people that were me." And so then I put myself aside because I grew up very differently. My father was an orthopedic surgeon. My uncle was a cardiovascular specialist. My mother was a teacher. So we have very different lived experiences, but as a healthcare system, we have to appreciate the lived experiences that people bring when they come into the health system and respect their total humanity.
Thank you. My name is Abner Mason, and I'm founder and CEO of a healthcare technology company called Same Sky Health. And what we do at Same Sky, we partner with health plans. So health plans are our clients, customers. We help health plans to create a more personalized experience with their members. What we have found is that if you treat everyone the same, you don't build trust, because we're not the same. People, just as you were saying, we all have a different life journey. And with respect to healthcare, we have a different level of trust for the health system. We have different willingnesses to engage in healthcare. The social determinants of health impact each of us uniquely, and that sometimes determines whether we're going to engage or not. We have different incomes and different health plans, or some are not insured. We all have a different life journey. And if we treat everyone the same, it's kind of saying that who you are doesn't matter. And what we found is that if you treat people like who they are doesn't matter, that their life journey doesn't matter, you're not going to build trust, and you're not going to be able to engage them, and you won't be able to navigate them into healthcare at the right time and the right place, which is what we all want. We want people to get the kind of care they need when they need it. We want to do it cost effectively. We want to do it in a good way for the whole person. But if people don't trust us in healthcare, they're not going to engage. And so what we found is that if we can flip that on its head, that concept, and instead of treating everybody the same, and I know that's sometimes easier, but it's not effective. Instead, if we can personalize the experience for every person, if we can actually think about this, if we could treat people, every person, like who they are matters, we can create trust, and that will lead to many good things in healthcare.
Well, thanks. Good afternoon. I'm John Pearl, and I'm the relatively new president and CEO of the Joint Commission. It's a privilege to be here at CAQH with some old friends and some new colleagues, and a particular privilege to be addressing such an important topic. As I mentioned, at the Joint Commission, it is a privilege to be there because we can impact policy and operations across the country and in 76 countries around the world. The vision of the Joint Commission is one that I think is really well stated. It's that all people always experience the safest, highest quality, best value healthcare across all settings. That's three alls. One criticism is that it does not actually state the word equity, but the positive side is that it does operationalize it. Our board is very supportive of taking a look at not only the vision, but the mission statement. And it's particularly supportive of an agenda that I brought to the Joint Commission, which we call the HELP agenda. HELP is an acronym for, at the very top, the H is health equity. The E is environmental sustainability, which also is an equity issue as well. L is learning healthcare, that we look at our operations and continue to improve. And P is that performance improvement itself. Now, you may wonder why I came to the Joint Commission so charged up about health equity. It's really the experiences that I had before. Most immediately, I had the privilege of being president of clinical operations at a large health system, HCA Healthcare. And before that, I had the privilege of leading the VA health system. And for the last 15 years, I was also a board member at one of the United States' 4 historically black medical colleges, Meharry Medical College. It was really during COVID that what was always unacceptable became intolerable. Some of the work that we had done across HCA, where we had the privilege of 250,000 deliveries a year, eradicated a well-known disparity, at least in the hospital. I think you know that women of color, Black and African American women, experience maternal mortality at rates that are 300 to 400% of white women. Latino women experience mortality at about 150% rate. Well, in 2018 and 2019, after a number of years of work, across 250,000 deliveries a year, no women of color succumbed. 0. In 2020, with the advent of COVID, that changed. There were 19 mortalities. Had nothing to do with hospital care. It had to do with dislocation from care, not treating individuals at all, frankly, whether specifically and unique to their needs or in any manner. Individuals with end-stage cardiomyopathies, individuals with cancers that were untreated, individuals with substance use disorders, individuals with mental health issues that needed care, and 2, actually, who succumbed to COVID. So, given the privilege of coming to the Joint Commission, the very first thing we did was actually create room for new standards addressing health equity. In fact, one of my favorite quotations on measurement is that not everything that's measured counts, and not everything that counts is measured. So we eliminated approximately 400 standards to reduce workforce burden, regulatory burden. Instead, we launched 3 things. At the top of that was a standard in health equity, a new program in environmental sustainability, and a focus on workplace violence. We also did something that some of our critics said was necessary. We didn't tell people how to address health equity. Your situation at Elevance, your situation in Philadelphia, your situation in California, and Chris, what you see around the country are all likely very different. And so we came out with what we call directional standards. It asked healthcare organizations to do 6 things: identify a leader, stratify their data according to social demographics, health-related social needs, identify a health-related social need opportunity, take action, review that action. If it didn't make improvement, rinse and repeat, and keep stakeholders engaged. We felt so strongly about that launch January 1st that we elevated it on July 1st of this year to a national patient safety goal, our highest level of focus. And we recently, at the same time, announced a new advanced certification in healthcare equity, which very important to this group, is being used in the Commonwealth of Massachusetts as the vehicle for their 1115 waiver, so that all 61 hospitals are now focusing on healthcare equity. And look forward to further discussion with this terrific group. Thanks.
Each of you to talk about what health equity meant to you, and this shouldn't be surprising. We got 4 related but different answers, right? So do we have a problem? I mean, how do we make momentum in something if this is a microcosm of the world and everybody's defining it differently?
Absolutely. I mean, one of my favorite books is Love Languages. So we all have a language of health equity, but it means something different depending on where you are in the system, in the healthcare system. Are you a payer? Are you a health system? Are you a health plan? And most importantly, don't forget, are you a community member? Because when that comes up, he or she has a different, or they have a different perspective. So I think, and again, and I said this on the call when I first met this group and was invited, I think it's important to have that muscle that Abner just talked about, to have those regulators, those associations say, hey guys, this is what we're doing. This is how we're going to define it. It may not be defined word for word, but these are certain characteristics that must be included when you start talking about health equity. And it starts with, from the health system, health plan, Abner's work, how do you see that person? What are their needs? Because the only way to get to equity is to address that individual's needs. You may need shoes, you may need a coat, I need transportation, you need housing, and you need treatment from substance abuse. So it's not a one size fit all. Equity is not that. It means meeting everyone where they are in terms of their needs.
Yeah, so health equity is definitely a multifactorial issue, right? And I think that in order to understand how we got to this health inequity, where did that start? And a lot of it, quite honestly, started with systemic racism. So policy is a big part of the solution, and we tend to dance around policy quite a bit. I did my MBA at WashU. I was here at one of the think tanks and on Capitol Hill for one of my modules, and they had a lecture that was addressing poverty. So I was really, really excited to hear this lecture. And the lecture was from someone who is a policymaker, and it was why people who make $300,000 a year can't get to $600,000 a year. I thought my head was going to spin off, and I said, I'm definitely going to fail this class because I am not happy. And I wrote we had to write about it, and I wrote about it to the professor, and I actually got an A, but I was not a happy camper. And I'm like, this is who is making our policy. So the first thing is we got to have representation at the table for policy making. But we also have to acknowledge that there's a need for systemic policy to reverse some of the things on how we got here. It's essential. And health equity, again, is multifactorial. Now, Elevance Health is there. We have our health equity accreditation from NCQA across all 23 of our Medicaid plans. We have very sophisticated analytics, and it's self-serve. So I've been suffering for quite a few months, but I finally got it down to a science where I can go in. I can look at neighborhoods to see who's at risk for, housing insecurity, who's at risk for food insecurity. I can look all the way down and see who gets more amputations from diabetes in a zip code than in another zip code. And then we have to act on that data. We have a very, very focused and enterprise-wide focus on population health. We have maternal child health swim lane. We have access to health swim lane, vaccinations, and it varies from plan to plan depending on what their data shows. I have 24 docs that report to me. They have a slide deck. Everybody has an initiative, and they have to work with the data. They're stuck. I see them get stuck, and I try to help them get unstuck to understand. I tell them, look at the data. Tell me the story the data is telling you, because that's what we're going to act from. So data is absolutely imperative. But the other thing is the coming to the table and getting coordinated. There's a lot of waste in the system because of a lack of coordination. And I think Dr. Perlman talked about trust, and Dr. Mason talked about trust, and trust is essential. I mean, I was out in the Midwest. I'm from New York. I grew up in the city in New York in the projects, and they got me out in Missouri. And I was out in Missouri trying to bring people together, and we were able to create a whole network of doulas across the whole state of Missouri to improve some of our OB outcomes. We identified our deserts. We brought our moms in from those deserts in the last few weeks of their pregnancy and housed them right next to the hospital to try to decrease their morbidity and mortality. So you have to be able to think outside of the box, but you have to have an organizational commitment to let you do these kinds of things. The other thing is allostatic load. We do this assessment called PHQ-9 for depression. So I'm an obstetrician by training. I'm 25 years at the bedside, but I've been in managed care for 10 years. And I'm doing rounds with the nurses, and I hear these stories. I'm depressed when I finish, and then you tell me their depression scale is 0. Can't be. We have to find another way to understand the stress that people are under. For 3 years, I've been asking this question, and I came across a nurse, and she said, have you seen the data on allostatic load? And it talks about the physiologic impacts of systemic racism on people. So this explains Serena Williams, Allison Felix, and the other young lady that just died, top physical condition. But the stress of the competition and being judged differently as a person of color has a physiologic impact. And so when you become sick, you're sicker faster and you die sooner. And that's what we're seeing, and that's what we saw in the pandemic. In the pandemic, if you look at IHI's diagram of the upstreamists, you can Google it. we've been down at the bottom, just pulling people out of the lake from drowning for many, many years. I mean, that was pretty much the model for managed care. And the pandemic forced us up into the middle of the model, where now we're addressing social determinants of health. We still have a ways to go to get all the way upstream around wellness, particularly to Medicaid patients. We talked about competing priorities. We give incentives, and then we sit at the table and say, why aren't they going to get their physical? We're giving them $25 on a gift card that may or may not work the first time they use it. But, you know, if you don't know where you're going to eat, you don't know where you're going to sleep, that's not the right incentive. So we have to find other ways. So the alignment is extremely, extremely important in conversations about, you know, things like this. We have, you know, incredible ED utilization, but they're opening EDs all over the place. Where's the disconnect? We don't want people in the ED. That's not the best place for them to seek care. But in Charlotte, like 3 new emergency rooms opened up. They're advertising on TV. How do they even get the certificates of need for that? And that's where we need the coordination. 2 books I want to recommend, and I'm going to give it up. One is Under the Skin by Linda Villarosa, which talks about the history of African Americans in healthcare and the impact of disparities on healthcare. And the other one is called Medical Apartheid. You know, profound reads. I was at Thomas Jefferson last week for a health equity conference, and a couple of people on pharmaceutical boards talking about, you know, including people of color in studies. And I was like, well, do you guys know the history of people of color in the United States in healthcare? And she's like, no, we don't. And I was like, you might want to investigate a little bit just so you understand why there's a reluctance. And, you know, not that it's not unfounded, but it's something that we need to overcome.
John, did you want to add something to that?
First, a +1 to all of my colleagues. Terrific comments. And indeed, when I think about my formative experiences training in Richmond, just as an aside, I never used the word, we're going to run a test on you. We talk about learning about more information, but never those words, for anyone who didn't appreciate the meaning of Tuskegee, especially in the South. Back to your original question, you know, in terms of aligning around what is health equity. One of the great things about the Joint Commission is that we can serve as an aligning force. We accredit and certify over 22,000 healthcare organizations across the United States. And through our work, we can address what I mentioned was our vision in terms of driving safety and quality and value, and especially equity. We do that in part because the Joint Commission, the reason the Joint Commission is called the Joint Commission, it's not about joints. Sorry to disappoint. It was jointly founded by the American Medical Association, American College of Surgeons, American College of Physicians, American Dental Association, the American Hospital Association. So it can bring together a number of different professions, individual membership organizations, along with the institutions in terms of driving improvement. But I think there is something that we do need to address profoundly in this issue, is that when we begin to think about disparities in health equity, we often frame this exclusively as a social justice issue. And of course it is. But the great health services researcher, Martin Luther King, had this absolutely right in 1996. He's often misquoted on this, but he said of all the forms of injustice, the most inhumane, he said of all the forms of inequality, the greatest injustice is, and most inhuman, is inequality in health. And the reason this is important is because he went on in that statement to say, because it often results in physical death. And when you look at it in this framework, it's no longer just a social justice issue. It is a patient safety and quality of care issue. Today, if you look at the data from the CDC, you'll find that Black and African Americans have an age-adjusted mortality rate that is twice that of white Americans. If using the OMB criteria, you look at American Indian, Alaskan Native, the death rate is even higher per 100,000 age-adjusted mortality. And so this is a tremendous issue. And from those of you who are at the payer community, whether you frame this as a social justice or a patient safety or health equity issue, it's also a finance issue. Because of the disparities, we end up in the long run paying about a third of $1 trillion more every year per the Kaiser Family Foundation. And if we leave this unaddressed by 2040, a full $1 trillion of avoidable healthcare expenditure because we haven't intervened at the fundamental level of redressing these safety issues and understanding the root causes that trace their roots directly to racism, to structural barriers, and result in disparate outcomes. And so, to the point that Abner made so eloquently, it's not one size fits all. It has to be in communities and with trust building approaches that address the unique needs of individuals. Equality is a one size fits all approach. Equity is actually seeking out the root causes to address the unique needs of the individuals to help redress the conditions that lead to disparate health outcomes.
Yeah, great comments. It reminds me a couple of things. On Abner's point, I was actually in a conversation. I'm on LinkedIn with a colleague, a physician somewhere else, and these issues that we're talking about here are not just issues of the poor and underserved, although they are worse in that category. A lot of people don't realize that. Check out the classic studies, Whitehall studies, or the social gradient. These were a series of studies done in Britain of people who were all non-poor. They were actually British civil servants, so government employees. They all had college educations, they all had good jobs, from the entry-level people all the way up to the administrators or the CEOs. And it showed an actually stepwise gradient. The higher you went up, the more you got paid, the more education you had, the better your health. None of them were poor. None of them were uneducated. So there is a component of this that if we just relegate this to the poor and underserved, that's great. We might fix that, but the problem won't go away because it's not just them. So we've got to have the personalized approach. Doesn't matter where you came from, it's who's in front of me, right? No matter where you come from. So I think it's incredibly important. But I got to push just a little bit more. As you know, before we turn to solutions, everybody's not in favor of this. And if we're honest, we're getting a bit of pushback in some circles about this whole idea. There was a little bit of excitement maybe in some people's minds. Oh, we've got more people being hired in equity positions and things like that. Those are being rolled back. They're losing their jobs. Or they're marginalized. They have a position, they just don't have any budget authority, Or, what do we do? How do we make forward momentum? How do we keep it going? And then the second question I'm going to ask you is, what do you say to the naysayers that the moral argument doesn't work? The social justice argument does not work. What do you say to them? What do you think?
I think is when you have the first part of your question is when you have people at the table like many of us, and everyone at the table isn't going to look like the four of us, and they're going to look like John, and John's going to be an advocate. But there's a responsibility to continue to bring the issue and the need to the forefront of the conversation. It can't be where just don't want to talk about it because there are people in the room that don't want to hear about it. So I think we have to have those like ourselves, those who really talk about it. Because what happens, one of the things, and I was thinking, there's the years of lost life, okay, that we're seeing as a society. And everyone has a role in this society. So if you take people, and this issue of health equity, to your point, when you look there, to me, when we look at this issue, there are four components, four facets. It's health, it's wealth, it's education, and it's social justice. Black and brown people aren't the only people in this country that are poor. Okay. So, and that, to your point with Dr. Martin Luther King, that's where he started getting a tremendous amount of pushback when he was putting together the Poor People's Movement. Okay. So many people who are hurting economically, hurting spiritually wise, or behavioral health. Behavioral health is one of the most significant needs that we have in this country. And that's not based on color, because back to the allostatic load and stressors, if you are a single mom in Kentucky with 4 or 5 kids, you're stressed. So how do we get natural allies to understand that we are allies and that we advocate for each other? And we have to, I think that's a big part of what we need to do.
Great. Anybody else? How do we keep momentum? What do we do to not let things get rolled back? What do we say to those that the moral arguments don't work?
I'll just add. I think one of the things we can do is to make the case that on a go forward basis in our country, the old way of kind of dealing with disparities, and I don't mean this in any bad way, but for anybody, but I'm just going to say there was a time when if you had 100, I'm just going to make it simple, 100 plan members, if you engaged, 30 of them, and as long as they win a lot, you could get paid for fee for service. The rest of them you could ignore, and it was okay. Or maybe you needed 40% to engage, you ignore 60. Whatever the numbers were, you could ignore probably half the population, engage half, make enough money, and be fine. Everybody get your bonuses, and everybody's happy. Going on the go forward basis, we are moving, maybe not as fast as people would like. We're moving away from that kind of fee for service. We're moving more towards value-based kinds of arrangements. I think that is the direction we're going. It's like a big battleship, or, it moves slowly, but that's the way things are going. So what I'm saying is, you can't ignore half your member population anymore. You can't even ignore 25%. So I think part of the argument is that it's an economic argument. On the go forward, we are going to have to do the thing that is morally right, but maybe the reason we do it is because it's financially smart. And that is, if you don't engage those hard to reach folks that you used to be able to ignore and just kind of not look at them, they're going to be so high cost for you that you're never going to meet your goals financially, and you're not going to be successful. And so I think we may be at a point where there's a wonderful virtuous circle, an alignment of good interests. The morally right thing to do is starting to align with the financially right thing to do, which is to figure out a way to engage all your members or all your patients, even those hard to reach, high cost, complicated, folks that you used to ignore, it was easy to ignore. I'm saying you ignore them, but they weren't focused on. Now you have to focus on them. So I think we should lean into that argument and lean into explaining that to people who don't get it. But if you take the time to explain it, they'll start to realize in a non-fee-for-service world, as we're moving toward more value-based, where you're going to have to, the way you get paid is based on how that whole population, you perform with the whole population, it's going to push us in a good direction. It's a happy coincidence.
Yeah, good. Sure.
So a couple of things. To keep it real basic is who's cooking your food when you go to the restaurant, right? You may not be invested in the conversation, at this level, at the work level, where you have to engage in things that make you feel uncomfortable. But who's cooking your food? Who's doing your nails? Who's doing all these things that make our lives very convenient? At the end of my emails below my signatory, I have a quote by Winston Churchill. It says, "A nation is only as well as the sickest citizens." And that's my function every day, to see how can we get people to their optimal health so that we can be healthy as an entire nation. And that's how we need to look at it. We have to push forward. And sometimes you just have to leave the naysayers behind. And so, I've been on like 10 meetings in the last week and a half on sepsis. And I told my team, I'm tired of talking about sepsis. We're getting ready to do an experiment. And we stratified our members, and we're going to provide certain services and do an assessment around we both went out, around sepsis, and to see if we can avoid readmission. Thank you. Around readmission to see if we can, around sepsis, so we can see if we can avoid readmission. So the naysayers, sometimes you just have to leave them behind, but it's a basic question: who's cooking your food? And, am I concerned about immigration in the United States? When I watched the news the other day and 300,000 people crossed the border, I am, because how are we going to take care of all of these people? If we don't take care of them, we get sicker as a nation. They just put all the immigrant kids in school in New York, and they just dropped our rates. We did such a good job last year. We were in a rebate. We had to give money back to the state. If you guys are not familiar, for every dollar, 85 cents has to be spent on the member. We're only allowed 10 to 12% in admin costs and 2 to 3% in margin, in profit. And if you don't spend 85 cents on the member, what they call the MLR, it goes back to the state. So we had rebate across the board last year. Some of it's still the residual effects of the pandemic. So they dropped our rates. We did so well. And now we have redetermination, okay? And what we're finding is the well members are leaving, and we have all the sick members that are staying. So it's a different, landscape that we have to navigate now with less money. And then, I was on a state meeting earlier today with New York, and my question is, when are you guys going to incorporate the immigrants, and what is that going to look like for us? Because we're going to have to start taking care of them. They're going to be coming out of fee-for-service money in the state, but they're going to switch that over to us for more efficiency. So, it's a lot to be concerned about, but I think if you think about things on that level, it may guide you to engage in the conversation.
Thanks. Three comments. Dollars, data, and leadership. On the dollars, I gave you the big picture, and Abner's comments really reflect on Berwick's point. Show me poor quality, I'll show you inefficiency. Show me inefficiency, I'll show you poor quality. Think about it, a little mind experiment here, that if you meander from a patient presenting and meander to a diagnosis, and then meander again to the right therapy, not only was that poor care, but that was also incredibly inefficient. And so the personalization is the opportunity to address these issues, the data. When I did my work in my last organization focusing on maternal mortality, we knew that there was a national challenge in maternal mortality. We knew that the data were horrific. But one of the reasons that we asked organizations, that we're asking organizations in our current accreditation program to stratify their data. I'll talk really loud. According to race, ethnicity, language, SOGI, payer status, zip code is not refined enough, block code, indices of deprivation, et cetera, is that you get really surprised when you look at things where you don't expect variation and you see it. I can tell you I've looked at data that have been adjusted for clinical comorbidities, and you find that there are differences in healthcare-associated infections, bloodstream infections, central line infections, and the like. And it's simply not explainable. And that creates a challenge for both the provider and payer side that said, okay, what do we have to do to get at the root causes of these issues? And then, having created, when I was running the VA, obviously a large, complex system, I sort of learned an adage. If you have a really big, intractable problem, make it bigger. And those data make that problem bigger, and they call out leadership. And this is point 3, leaders lead. Create conditions where you can't look away.
So there may be some of you out there that don't know anything about you, but because the data indicate that there are people like this in the country that believe, there might have been a day in this country where we were doing things wrong, but today it's about people just aren't, they're lazy, they don't want to work, they don't want to eat right, they don't want to do the right thing. And that's what you need to focus on rather than this. Well, Jonathan brought up the Tuskegee syphilis experiment. Let me just do a quick question for you. Anybody know when that started? What year it started? Yeah, it was in the 30s, 1935, I believe. Anybody know what year it officially ended? 1972. And the only reason it ended then is because a news reporter picked it up and put it in the news, and it got all over the country. 1972. We were all alive in 1972. But let me go one step closer. It isn't just stuff that happened back then. forced sterilization. We talked about Indian populations. It's actually also even military populations, right? Populations who don't have control over their own bodies. When was the last time in your mind you think forced sterilizations without consent were done on women in this country? 80s? Anybody else? 85? 2000? Boom! During COVID. During COVID, in some places, prison systems in California, I believe a few in New York and a couple other places last year and the year before, particularly on immigrant women, but not only immigrant women, forced unconsented sterilizations. It's happening now, my friends. It's still happening. We don't like to talk about it. It's part of the difficultness of it. But if we're going to be honest, we got to be honest. So to that point, I'm not advocating for it, but it's starting to percolate up. I want to know what you think about it. Talked about what do we do? How do we move it forward? What do we say to those? With these realities there, what role do you think in the future product liability or litigation will have? We're seeing some of that already, but do you think that that might be a prominent role? You may not want to go in this direction, but as decision as a to hedge your bets and to keep expenses down. What are your thoughts on that, if any? Anybody?
I think it's probably a mistake, not probably. It is a mistake for us to rely on just goodwill for people to do the right thing. If it were just goodwill, we'd have a healthcare system that was equitable today. So I think if we accept that just goodwill is not sufficient, then we need to align other pushes and incentives, and one of those is accreditation. And what you're doing, again, I think it's just fantastic. This is like miraculous to see large accreditation bodies like the Joint Commission and like NCQA saying that you're not going to get accredited. It means you can't operate your hospital if you don't do these things, or if your health plan, if you don't have the accreditation. For instance, in Medicaid, now certain Medicaid, the state directives of Medicaid, the agencies are saying you can't bid on the contract if you don't have the accreditation. So it's a virtuous circle. You got to get the accreditation in order to win the contract. These contracts are 5-year, every 5 years they're worth a lot of money. So the plans say, I got to get the accreditation. And so it starts to align their interests. And I think that moving forward, not that, I'm not supposed to like litigation, but let's face it, this is America. One of the ways we get people to do things is we make it clear to them if they don't do the right thing, they expose themselves to liability. So I think we have to align. We need the incentives aligned in a good way that encourage people to do what they ought to do anyway, but won't unless they have the incentives.
Yeah, I'm not encouraging it, but some people argue today that more was done around tobacco cessation from the litigation, the $1 billion litigation, than all of public health and medicine. Anybody else want to comment on that?
Yeah, I think that, we just saw it used for abortion.
Yep.
They're shutting down services all over the country by law. All right. So these things that happen, unauthorized sterilizations and things like that, as recent as 2020, 2021, there should be some kind of law. There should be some kind of litigation to keep people from doing that, because, the morality of it and the common good does not speak to everyone. They have different incentives to do things. But I think overall, in this conversation, the accreditation is a form of accountability. And to have the cadence around accountability, I think, let's see my couple of words I wrote down here. Thank you. Planning and coordination to take the waste out of the system, and the building trust, and then focusing on outcomes. So my daily life, I live in a short game. Every year, this is budget time, and I have to put stuff on the table, how I'm gonna save money from this year to next year. And I'm putting out sickle cell initiatives. I'm putting out, doula initiatives, something around sepsis, something around diabetes. And those are 3 to 5 year, those are long games. And so I'm saying to my leadership and to my analysts, and finally I got this chief analyst to say, we got to look at this differently. This is going to take longer. I'm like, yes, thank you. This is how we have to start looking. We have to be looking at outcomes. And the outcomes will eventually affect the finance, but the outcomes is what's going to get us ahead as far as the health of the nation and doing the right thing.
I think one thing that we have to do is to, I think healthcare has a tendency to talk to itself. So we're, like minds and we're talking to each other. And I think we have to engage other parts of our society, particularly where we know we live in a capitalist society. So if we engage business members, business community members, and we talk about those, years lost, the earnings that they're losing, to your point, who's cooking your food, who's showing up to work, who's not showing up to work. How about that mom who has a kid that is asthmatic? She's okay, but she has to take off because she has to stay home with the kid or spend all day in the ED trying to get the kid care. So we engage those partners, and particularly as a health system, we have to move to that model of some of our friends who are out in Chicago with you, Rush, where we have these anchor health networks where we look at the economics, because part of how we got here is driven by economics and the lack of valuing certain people's lives. And how we can get out of this is through economics. One of the things you can do is we all health systems and health plans, we're missing people, particularly direct care providers, care managers. What do? Why not tool people to be able to be in those seats in these organizations? That's another place. So that's where that education piece comes in, because we're always going to run the cost that we have for staffing now, that particularly like a health system where we're doing temp staff, the cost of that is greater than bringing someone in-house. So how do we work in our communities to tool people to be a part of our health systems? And one of the things we're doing is we're doing community health workers, okay? We have an initiative right now I have in my shop. We're bringing people in, we're training them for a year, and we're paying them while we're training them to learn how to be community health workers. At the same time, we're lobbying different parts of our health system to say, hey, we put them there for you with a 3-month pop, 3-month over here. Where can we land? Where's the off ramp so this person can be a fully employed person at the end of this 13 months?
Fantastic. We want to hear from you. So get your questions. If you have a question, raise your hand and a mic, either mine or someone else, will come to you. We need you to talk. Oh, it's in the back. We need you to talk into the mics because it's being recorded, not that we can't hear you. And the panel already went to the last question I was going to ask them. We've talked about the problems, we talked about the barriers, we talked about the issues. We've heard some amazing, what the Joint Commission is doing, what Elevance is doing now, what others are doing. What are the bright spots? We already got some good examples. Before we take a question, are there any last sort of solutions, techniques, tools that we haven't mentioned today that are immediately actionable that the folk in the audience could take back and think about that could help in this area that you want to mention to the audience? Anybody?
I'll just note that, because of the work you're doing, I just commend some of the work in Massachusetts. As I mentioned, they've got an 1115 waiver around the Joint Commission's advanced certification in healthcare equity. The requirements for that are fundamentally the same as what is absolutely mandated in the accreditation, except that it requires 3 additional things. One is full engagement of governance, and an approved strategic plan, 1 and 2. And the third that's the first. The second is attention to diversity and leadership in the organization itself. And third is engagement with community stakeholders broadly. So it's a pretty good framework. And along the lines of framework, we just note that we've put up a health equity resource center that actually has some pretty good resources. And as the stories come in from, as my colleagues have noted, that not everyone's situation is the same. Transportation may not be an issue in New York City with New York Health and Hospitals broadly located, but food insecurity, obtaining medications, there may be other issues that in a particular area, someone has found a solution to. And so we'll be putting those sorts of solutions back up. Finally, beyond the moral argument, beyond the clinical patient safety argument, we know about the return on investment. We know about the return on information, the return on quality, return on safety. It would be great to share lessons learned on return on equity.
Anybody else? Last words?
I would just, it's important for us as we're always to talk about what should be done, but I think it's important for us to be self-reflective of just a minute. And so I'm going to just ask this for those of you who work for a plan. If you come from a plan, a payer, don't raise your hand. But how many of you know, let's say, 75% of your members? How many of you, for 75% reaching that threshold? How many of you know race of your members? 75%. How many of you know their preferred language or their ethnicity or their sexual orientation or their gender identity? Or if they have any of the sort of, even the high level social needs, do they have food insecurity? I mean, at the individual level, if we just pick, if you don't know that about your members, and I'm not going to ask, but I can almost guarantee you most of you haven't hit the 75%. Most aren't even at 50%. If I talk about, race, ethnicity, SOGI, we got to do better. I mean, you have to do better. There's no reason why today in 2023, you can't know that about your members if you want to know it. And I can guarantee you this, if you know that about your members, you will build trust with them in a way that you're not today, and you will engage them in a way that you're not today, and you will save money. You'll be able to navigate them into healthcare at the right time, in the right place, in the way that you're not today. So as much as we want to talk about what others can do, I do think it's important to be self-reflective, and you can do something now to move, to make progress in this way.
And to bust a myth on that one, it's not illegal to do that.
No.
There was a lot of feeling for several years that, well, we love to, but we can't ask those questions. In fact, Commonwealth funded a study that looked at that policy analysis. And in fact, was that not true? But there were many policies that actually mandated or asked them to do it. And oh, by the way, that was done 25 years ago. It's still true today. Anybody else?
There was this myth that we couldn't text Medicaid patients, we couldn't reach out to them, and then the pandemic hit and they were talking to their doctors on Zoom and they were doing their visits on FaceTime. So that myth was killed. But for the folks that work in healthcare and you're working with the clinical people and you're working with the finance, the CFOs, those are the ones. And they keep saying, oh, all these high utilizers in the ED, all these high utilizers in the hospital. I'm going to give you this muffin analogy. So I'm on with the team and they're talking about the high utilizers in inpatient. I was like, guys, that's the frosting. They need a completely different touch. Let's get to the muffin top. Those are the emerging risks. Those are the ones that we can get our arms around and stop them from becoming sicker, slow them down on their inpatient and ED utilization and their readmission. So when you go back to your workplaces and everybody's talking about that icing, keep in mind, that's like 5%. And you have the other, 15% of that 20% that drive your costs in that muffin top. And then you have the rest of your population. So I just want to give that image.
Prevention paradox. That's what she's talking about. There's a book written by an eminent epidemiologist called The Prevention Paradox. A simple read, a good read. You'll learn a lot about that. All right. Any questions? Any hands? Thoughts? Disagreements? If you disagree with something we said, we'd love to hear it. Not that we'll agree, but sure.
Yeah, thanks so much. So one of the issues that we've seen is actually some Medicare patients are already experiencing inequitable delays in care. And we know that a lot of this has to do with value-based care and that there's disincentive for some practices to continue with those patients because of they're not able to keep the lights on because of the way things are structured. And we know that when care is delayed, health outcomes are worse. So I was wondering what remedies you might suggest from your erudite perspectives on these problems with regarding particularly the impact on minoritized and marginalized patients and those who live in rural areas.
So are you asking about how do we fix value-based purchasing or
value-based care
Value-based
to
care.
address the needs of
Yeah.
the minoritized, marginalized populations?
All right, guys, girls, ladies, sorry.
Yeah, I mean, that's a good question. I mean, I'm doing something on sickle cell now where I'm looking at incentivizing the specialists within that model. And so I think there may be some opportunity. I haven't worked Medicare in a few years, and I had a very small population when I did. So we were able to get our arms around them and kind of get them engaged, particularly in New York, because we have physical places that they can go. And in that age group, you know, they tend to print stuff out, right? They don't like the internet and that kind of thing. Not all, but many. So I think perhaps looking at some type of specialized incentivizing, but I think also again, it's that the coordination. If they can't reach these members, how are we helping them to reach these members? And what are the barriers to why they can't reach these members? And I had a very prominent pediatric group in Virginia telling me that they'll see a sick patient, you know, because they know they're going to get paid and they're going to get paid more based on the coding versus seeing a well patient. And we're trying to close the well patient gaps. So I think kind of looking at the barriers as to why they can't get to them, how can your company help them engage those members? And again, it's really thinking outside of the box and moving the care to them. We always want to bring the care, have them come to the office. Maybe we need to be delivering care at home.
Particularly for the older patient. So we're actually starting working, my entity, like I said, is called the Community Jefferson Collaborative for Health Equity. And we're working with our primary care service lines, as well as our population health on the patient side, because we have the School of Population Health. And we are working, we're at this table, so I don't have an answer. What I'm saying is we're coming together now to say, how do we work together to address this in advance of rolling out some of the value-based care? The reason they want me and my team at the table is because we have those community health workers. So what we already know is, to some of the point, people don't show up to care because. So our community health workers are calling to find out, do you need TransPass? Is it because there's something else more imminent that's going on with you, that you're about to be evicted? How do we navigate you to resources so that you can stay at the table to be able to begin your healthcare journey? So I think part of what we're doing as a health system is we're bringing different entities together to say, before we really kick this off, how do we need to do this? How do we need to coordinate? How do we need to link arm in arm with various different business units, for lack of a better word, in the health system to be able to support the work of our providers as well as serving our patients?
The privilege of serving on MedPAC for a number of years, Medicare Payment Advisory Commission. And, one of the challenges in terms of providing appropriate reimbursement for more complex patients was that, just to Dr. Gibbons' point, we don't collect the data. Had we better data around the individual, not the aggregate of the individuals, but the individual, then payment would be better calibrated. So I think this is one of the things we'd encourage, advocating to MedPAC that those data are an absolute essential toward both driving the outcomes, but also assuring that the process aspects, including access to services, are available.
Great. Anybody else? Any other questions? Thoughts? I think there's a hand over there.
I can speak loud.
Yeah. We're all having a problem.
So from Mississippi, and if you look at any demographic charts or anything, we're always dead last in pretty much everything. Nope. All right. All right. So if you look at northwestern Mississippi, the Delta area of Mississippi, one of the most underprivileged areas in the country, by far. As a health plan, meeting time and distance standards from having a doctor in those areas, almost you're just never going to meet it. And so, from a health equity standpoint, how do we incentivize doctors to go into those areas where doctors just don't go? And then even to build beyond that, Mississippi is one of the only states that have decreased in population since the last census, and we're losing all of our doctors that are quality and capable to other states. Well, hey, if I've got an opportunity to go to UCLA and do an internship, I'm going to go there instead of staying here in Mississippi. So what do we do from a rural standpoint there to incentivize physicians to stay in that neighborhood?
So I'll offer a few thoughts, and then I've actually been down there with one of the clients we had. We went down there, spent some time, so I know the area pretty well. But I think one of the things you're hearing from all of us is that this one size fits all approach just doesn't work. And even if you have one right thing, one thing won't work. I mean, you'd think I was crazy as a physician if I told you I got one pill or one surgical procedure or something that will cure whatever disease you're talking about across the entire lifespan in everybody. It doesn't work that way. It never worked that way. So why do we keep trying to think that way now? What needs to happen with all of these problems, I know there are difficulties, is a variety of approaches. So specifically with the Delta region in Mississippi, we went down there because they have actually the Center for Telehealth is one of the more robust centers for I visited 8 years ago. One of the more robust centers for telehealth in the country. UVA has the oldest one. And at the time, Christy Henderson was leading it up. She's gone and went to Amazon, a bunch of places. But they were doing some amazing work. So your question was about physicians. That's a tough nut to get for a whole lot of reasons. The money, the area, the everything, but you got to work on it. I'm suggesting in addition to that, there are other things you can do to be able to get the care to places. Telehealth, they're doing a lot down there with satellite clinics. This is long before pandemic, right? They were already doing it. They're the only medical center, tertiary academic medical center for the entire state. I think it's 94 counties you got out there. So they provide care in every single one of them. So I just suggest multiple approaches, looking at not just telehealth, but new remote patient monitoring, other kinds of things. And there are more things coming online that can augment and supplement, and they're showing results. They tout a platform that they have that's doing well. Also looking at the manpower issues as well.
I think mobile units are a way, we're moving away. We're going to telehealth and, monitoring devices and everything. And there's a place for that. And like I tell my teams all the time, there's never one bullet. Right. It's always multi-pronged. So you have a provider solution, a member solution, a technology solution, and so on, an education, a communication, all of that. So I think there's a space for, I have this idea of these roving vans that come in to the point that people know when they're coming, so they come. So I've done mission work in Nigeria. I went to Haiti for the earthquake. People knew we were coming. They were there when we got there because they knew we were coming. So I think to set that type of mentality in those areas and then provide them continuous services. The other thing, though, is building your pipeline. The pipeline starts in elementary school. So getting the children exposed to folks that look like them or live where they live, that are practicing medicine, taking them outside the community. But you have to build a pipeline. I mean, several years ago in the U.S., the AAMC had a goal for 2,000 minority physicians by 2000 and failed. So the pipeline building, they try to start it in high school. It begins in elementary school, getting them exposed to STEM and supporting them, giving them, I had one of my kids doing some work at Johns Hopkins when he was in middle school, whatever it took to get them exposed. So I think, looking at your pipeline, and that's a long haul. And then the other thing is incentivizing physicians to come, loan forgiveness, that's going to be, again, policy. That's going to be state and federal. Getting folks in, if it's we're concerned about healthcare delivery in these areas, getting students to go into primary care. I mean, I have 2 daughters and both are anesthesiologists. I'm profoundly disappointed. And nobody went into, I'm OB, nobody went into primary care. I was like, what's wrong with you people? like, this is my work I do every day. So, incentivizing them to go into these specialties, pediatrics, OB, prime family medicine, internal medicine is extremely important, and starting to work on the pipeline and then doing those intermediary things and then putting technology on top of that. So it's a multi-pronged approach.
If I could just piggyback on that, we know early life experiences are profound motivators for later educational, even before high school, quite honestly. So although it's a long-term play, it can be incredibly important, giving those early experiences for youngsters, and then later they do it as one way.
So where I want to say that is, again, so we've been you talked a little bit about downstream and moving upstream. And to address this, we actually have to do those, erase some of those structural barriers and address those systematic issues. And one of the issues that's systematic is education in this country. And so it's great to talk about the pipeline, so you can expose kids and you can talk to it, but do they have the basic skills? I saw something the other day, how many kids, and it was someplace in the Southeast where teachers had come together because kids had gone back, and it was a multiracial group of kids that are 2 years behind in reading level because of the pandemic. So if we had a pipeline issue before, we really have a pipeline issue now. So what is it that we're going to do structurally, systematically in this country to address the education issue? Because that's another place where there's a tremendous amount of inequities. And it's, my husband and I used to talk about, it's a civil rights issue of the 1990s, 2000. Because if you don't have access to good education, how do you move forth through the pipelines? And we all know education, you just talked about, is a variable that will tell you where you're going to end up in your health outcomes. So that's another, this is where that policy, structural, systematic addressing comes in.
And then education, community, employment, that's health. That's health. My mother-in-law is a pediatrician. She lived to 92. She was a smoker. She lived to 92. My mother was a high school graduate, hard worker. I got a good work ethic from that lady. And she died at 71. 21 years in between, just on the basis of education. Education is health. Education is health, community is health, and employment is health as well.
I want to give a shout out to my alma mater, Department of Veterans Affairs. It's one of the few environments that can really treat the biopsychosocial model. There's employment, to the points that were just made. There's education, the points that were just made. There's memorialization at the end of life, the points about really considering the patient's, the entirety of needs. But one of the things I was most proud of, when you think about the VA, not all people who served are eligible for VA care. But the group that does use VA care is systematically older, sicker, and poorer. 2/3 are over 65, 3 additional physical, 2 additional mental health diagnoses, 68% with incomes less than $26,000, about half that with incomes less than $13,000 per annum, and 23% with food insecurity, defined as 2 or fewer reliable meals daily. These patients, but for the fact they're veterans, very much resemble the social need profile of dual eligibles. During the period that I was undersecretary, by implementing telehealth, by increasing the length of primary care visits, by increasing the length of initial intake visits, not only did the cost per veteran go down, but when you looked at if you looked at function on the SF-36 or the SF-12, the veterans' function actually improved and longevity increased. It's a remarkable social experiment. It's counter to many of the ways that we approach care. So it's all in the literature, and would encourage you're having a look at what happens when you do things a little bit differently. And it's sort of like a large concierge approach, recognizing the unique needs of individuals, but with a systematic approach to that. Thanks.
Well, it's been a pleasure being with you today. Hope this session has been valuable to you.